Welcome all the participants. One of the important problems when you deal with diabetes is none other than high sugar, which is uncontrolled diabetes, uncontrolled blood pressure. So that is A and B. But C, which is high cholesterol, actually is the most important problem because raised cholesterol, specifically raised LDL, low density lipoprotein cholesterol, is extremely important. It is a cause of atherosclerotic cardiovascular disease. And you know very well that more than 3/4 of the patients of diabetes get hospitalized because of some vascular problem. And more than 2/3, that is more than 65% of diabetic deaths are attributable to cardiovascular disease. So diabetic dyslipidemia happens to be a very, very vital part of discussion and management. And basically, this is something which I am starting with a very important slide right away. We know very well that diabetes, especially type 2 diabetes, is featured by insulin secretory defect from the beta cell. Beta cell number may be less, or it is insulin resistance, which is chiefly contributed to by the skeletal muscle insulin resistance, adipocyte insulin resistance, and hepatocyte insulin resistance. So if we look at the adipocyte, because of the insulin resistance, you can very clearly see that there is more of triglyceride hydrolysis or lipolysis rather than lipogenesis. So whatever fats or excess fats which are ingested, rather than getting accommodated into the adipocytes, because of insulin resistance, the adipocytes, they actually try to release most of these into fatty acids. So there is what is called as lipolysis rather than lipogenesis and storing the fat in the adipocytes. So these free fatty acids, as you see here, they come more and more in circulation. So when you look at hepatocyte, then the excess influx or incoming free fatty acids can certainly cause lots of problems. So if we closely see, then the metabolism inside the hepatocyte, there is beta oxidation, which goes up. Gluconeogenesis and thereby hyperglycemia is something which is encouraged. And the lipid storage unnecessarily, rather than in the adipocytes, the lipids, the body tries to accommodate these lipids in the hepatocytes. So that creates what is called as hepatic steatosis. And the latest name of this is metabolically associated steatotic liver disease, or MASLD, which, if you have listened to me in the last lecture, I was talking about fatty liver or NAFLD or MASLD. Now, these free fatty acids in the hepatocyte, there is an excess generation or creation of triglycerides. You know very well that triglycerides are nothing but one molecule of glycerol and 3 molecules of free fatty acids. So that triglyceride generation goes up in the hepatocyte, and this excess triglyceride is secreted or assembled into VLDL, which comes in the circulation. So this biochemistry is very, very important to really appreciate. Now, the other part of the story is from the intestine, the chylomicrons or chylomicron remnants, and the enzyme which is called as lipoprotein lipase. So in diabetes, there is excess generation of free fatty acids from this source as well. And that's something which is very, very importantly appreciated by the students. Now, what about the hepatic VLDL clearance, or what are the other repercussions of excess VLDL which is being secreted by the hepatocytes? Look at that. So this hepatic VLDL clearance or secretion, that actually results into a lot of other changes in the other lipids. For example, you will see here that these excess VLDLs, they are processed on, they get converted into VLDL1, and this VLDL1 down the line is processed on or acted on by lipoprotein lipase, which creates VLDL2, and then down the line it creates the low density lipoprotein or LDL cholesterol, and the other is triglyceride enriched LDL cholesterol. Now, this triglyceride-enriched LDL cholesterol is again acted on by hepatic lipase and cholesterol ester transferase protein, or CETP, which makes it small dense LDL. This small dense LDL is the real villain as far as the atherosclerosis pathophysiology is concerned. So this is the basic important slide which all of you should keep in mind. This is the pathophysiology of diabetic dyslipidemia. I have tried to fairly simplify that. It is far more complex than what actually I had tried to really show in the diagram. Now, with type 2 diabetes, we use lot of drugs. So these lot of drugs, especially like maybe metformin or maybe pioglitazone, then glibenclamide, gliclazide, glimepiride, different gliptins, then different GLP-1 receptor agonist, different SGLT2 inhibitors, alpha glucosidase inhibitors, or maybe some others like miglytol, bromocriptine, cholecyvalum, which we don't use much in India, and different insulins. So generally, all these anti-diabetic drugs have some effect or the other on the triglyceride level, on the HDL level, and on the LDL level. Generally, you will see that metformin reduces the levels of LDL. Pioglitazone, rosiglitazone, they take it up, but that LDL is more buoyant or less dense. So it is not much of atherogenic. The sulfonylureas, broadly, they don't have much of effect on LDL. And gliclazide, though, decreases the triglycerides. Gliptins, some gliptins certainly show reduction of triglycerides like Sita, Vilda, Aloe, etc. And Aloe also has shown reduction of LDL. Similarly, Vilda also can reduce LDL to some extent. And then the SGLT2 inhibitor, GLP-1 receptor agonist, which especially exenatide, liraglutide, they have been shown to reduce LDL. Why I am repeatedly mentioning LDL is, as I told you, LDL is the cause of atherosclerotic cardiovascular disease. And that's why if LDL is reduced, that is certainly going to be beneficial as far as ASCVD risk reduction is concerned. So, and these are the other drugs, like, for example, the ACE inhibitors, beta blockers, angiotensin receptor blockers, calcium channel blockers, different kinds of diuretics. They also have some beneficial and some maybe not so beneficial effects on different lipid parameters. Analgesics like NSAIDs also have some effects on the triglyceride levels or LDL levels. Aspirin can reduce TG, can reduce LDL to some extent. Oral contraceptives, as you can appreciate for female patients, then levonorgestrel and desogestrel, they certainly can increase the levels of TG, increase the level of LDL also, but the desogestrel, that can reduce the level of LDL. And then hormone replacement therapy, estrogen is circulatory friendly, so estrogen certainly reduces the LDL level. And vitamins, mind you, vitamin D, that is neutral as far as LDL is concerned, but vitamin B12, ascorbic acid, that's vitamin C, and polyunsaturated fatty acids, they can certainly reduce the levels of LDL. So all these you need to be, you can say, aware about, because these may not be lipid lowering drugs, but they are certainly used very frequently for sugar lowering, for blood pressure, for obesity, or maybe standard hormone supplements or nutrition supplements. Coming to the 2023, because that's what is my title, Managing Diabetes Dyslipidemia in 2023. So 2023 American Association of Clinical Endocrinology guideline, the latest from them, and this is the lipid or hyperlipidemia management. So they ask you to assess the lipid panel, LDL cholesterol, HDL cholesterol, non-HDL cholesterol, triglycerides, and apolipoprotein B. That's something which is important. They say that lifestyle intervention certainly remains the foundation. Increase dietary fiber, increase healthy fats, reduce saturated fats, reduce simple or refined carbs, stop added sugars, increase physical activity, and try to control weight, especially if it's overweight or obesity. Then, if the patient is diabetic, assess the other risk factors like hypertension or albuminuria or reduced eGFR, etc., because they also can add to ASCVD risk. Smoking, of course, is to be stopped. And then looking at the lipids, the basic theme or basic advice which I want all of you to appreciate is LDL number is not something which is to be chased. Very important. It is the baseline or background risk of ASCVD, which should be estimated. So, if the ASCVD risk broadly, as per the American Heart Association, American College of Cardiology, ASCVD risk calculator, if the risk is less than 10, diabetes duration less than 10 years, less than two other risk factors, and no target organ damage, then this is moderate intensity statin requirement. And LDL target should be less than 100. Now, if the risk is very high, for example, between 10 to 20%, diabetic duration more than 10, patient's age more than 40, no established ASCVD, no target organ damage, but more than two additional risk factors. For example, strong family history, obesity, dyslipidemia, smoking, etc. If that is there, then the LDL target should be less than 70. Let me tell you that our Lipid Association of India generally recommends that most of the diabetic patients, the LDL target should be less than 70. So even if you keep that in mind, I feel that is sufficient. And then the non-HDL target less than 100, because generally, LDL and non-HDL, the difference is generally 30. Triglyceride target less than 150. ApoB target less than 80. If the patient has very high risk, so type 2 diabetes, established atherosclerotic cardiovascular disease, severe target organ damage, EGFR less than 45, urinary albumin creatinine ratio more than 300 milligrams of albumin per gram of creat, ankle brachial index less than 0.9, LV systolic or diastolic dysfunction on the echocardiogram, then LDL target is less than 55, non-HDL less than 80, TG less than 150, ApoB target more stringent, less than 70. So that's something which you have to keep in mind. And hypertriglyceridemia, especially if it is more than 500, then certainly you need to really look at that as a separate target, because you want to prevent risk of pancreatitis. So which scores? I told you that LDL number is important, but more important is to which target that LDL has to be lowered. So as I told you, very, very high CV risk less than 55. High CV risk less than 70. Moderate CV risk less than 100. That's the broad target. What is required to decide the CV risk? So I alluded to the popular American College of Cardiology, American Heart Association pooled cohort CVD risk calculator. It is available on most of your smartphones, or you can use the other risk. For example, Renault CVD score, Framingham CVD score, multi-ethnic atherosclerosis or MESA risk score. European countries advise what is called as a systematic coronary artery risk estimator, and they have actually gone on into the details. Different countries have different scores in the Europe. So, and in India, they say that you should be using more of Q risk score rather than anything else. So we use Q risk score. So whatever method you use is not important, but you have to estimate the CV risk and then go ahead to target the LDL to a destined numerical value. Different statins. Now, what is the low intensity statin? What is moderate intensity statin? What is high intensity statin? So this is not the, you can say anything fantastic, nothing pharmacological. What is the LDL lowering which you can expect? So if it is a high intensity statin like atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams, you can expect more than 50% LDL level lowering with high intensity statin. That's why they have called as a high intensity statin. So now you will understand that if somebody's LDL is, let's say, 130 and you want to take it to something like 70, then you will require certainly high intensity statin, because otherwise that target is very, you can say, difficult to achieve. And very, very importantly, the statins are something which are the pillar of diabetic dyslipidemia management. And then we also have other statins like simvastatin, pravastatin, lovastatin, fluvastatin, pitavastatin, different powers, 1, 2 to 4, or maybe pravastatin 10 to 20, 40 to 80, etc. And depending on the requirement, depending on their pharmacological doses, they can be categorized into low, moderate, or high intensity statins.